much, Bert, for the kind introduction. Yes, I chaired the Swiss National's COVID Science Task Force, and in that capacity, some people called me Mr. COVID. And this is, of course, the topic of today. So I'm going to talk about the COVID pandemic in Switzerland. And I'm going to first introduce, and we already had a chat about this, Bert, the inverse care law and our late friend Julian Tudor Hart. Then I'm going to talk a little bit about the situation in Switzerland and how the pandemic evolved in our country. I'm going to introduce the Swiss Neighborhood Index of Socio-Economic Position, SEP, and talk about surveillance data that we analyzed and present results on 5 outcomes and 3 denominators, and discuss some implications and strengths and weaknesses. I would like to stress that this is really work in progress and it's unpublished, and we are actually at the moment updating the analysis, and that's Julien Rioux and Radoslav Pančák, who are also on the call. They will take all the questions, and they have been basically doing a lot of this work. So thank you, and also thank you to the people at the Federal Office of Public Health who provided us with data, and people at ETH. So the inverse care law is a phenomenon that is observed in different contexts, and as I will show, also in the context of COVID-19. And it goes back to this article, which is more a political, I read it again this afternoon, it's more a political piece, but it makes the point that the availability of good medical care tends to vary inversely with the need for such care in the population. And also very interesting and relevant to Switzerland, this inverse care law operates more completely where medical care is most exposed to market forces, and less so where such exposure is reduced. And that's, of course, also very relevant to the United States. You can get access to this article on the webpage of the Socialist Health Association, and you see the link there. Now, who was the author of this radical piece? It was Julian Tudor Hart, who died in 2018, who was a really, everyone who met him will say, an impressive personality. He was a GP who worked in Wales, in a deprived mining community in the southern part of Wales. He was clearly a pioneer of primary care research in the UK. He was the first primary care researcher in the UK who got funded by the Medical Research Council. And famously, he was the first doctor in the UK who actually bothered to measure blood pressure of all his patients and published these data and tried to prevent strokes by lowering blood pressure in his patients. And this was so successful that it could be shown that in his village where his patients were, mortality actually declined compared to the neighboring village. So one person, one engaged GP who believed in preventative medicine could actually reduce mortality by 28% to be precise. This was recognized. He became a fellow of the Royal College of General Practitioners and Physicians, and he was always a very politically active person. He was a member of the Communist Party of Great Britain, and he stood unsuccessfully 3 times as candidate for Parliament, 64, 66, and 70. So he was a really impressive personality who fought for the National Health Service and against private medicine. And we'll get back to that in a minute. Now let's have a look at the situation in Switzerland. And not everyone will be familiar with Switzerland, the country in the small country in the middle of Europe with a population of about 8.6 million. It's a relatively healthy population. The political system is federal, a bit like in the US, and the cantons are responsible for health. It has a high living standard, a high GDP, low public debt, and a globalized economy. It attracts a lot of talent. It also has many challenges. It has an aging population. It has a costly and fragmented healthcare system, and we'll get back to that. And it is really lagging quite badly in terms of digital transformation. This also became evident in the context of the COVID crisis, where GPs, doctors were faxing reports to the Federal Office of Public Health. Now let's have a look at the cases per million people taken from One World in data, and you see that the first peak, Switzerland was sort of similar to the neighboring countries. You see here Germany, Austria, Switzerland, Italy, and the US. And you see that the second wave, really Switzerland went through the roof. We even beat the US, as you see on this slide. And noticeable is, in my view, Germany, which was, below Switzerland in the first wave and clearly below Switzerland also in the second wave. And you see the other countries, Austria and Italy, similar, slightly better than Switzerland. And you see the US with this huge increase here during December and January. Now, Switzerland's policy response was, let's say, special. People talk about the Swiss way, a bit like some people talked about the Swedish way. And you see here on this graph, you see the Oxford Stringency Index. This is an initiative by the University of Oxford, which aims to assess how stringent measures against COVID are by different countries. And you see here the comparison with Germany. I've already alluded to the fact that Germany and Switzerland are actually, they're quite similar in many ways. They're both federal states. They're both, economically strong states, but they had very different experiences in this COVID crisis. And you see that Germany, during the summer, when there were few cases, maintained a considerably higher index of stringency. In other words, they had restrictions on how many people could meet, which Switzerland didn't have during the summer, except for more than 1,000. So everything below was possible. There were loads of parties going on in the summer, etc. So the stringency of measures was clearly in the European comparison, not only with Germany, was less in Switzerland than other countries. And the consequences of that, you can see on this slide here. You see that the effective reproduction number was actually above 1. So you get a exponential growth, slow, but it is exponential during the summer, and in the autumn then the big wave that we saw on the previous slide hit. Whereas in Germany, I don't show this here, but in Germany the effective reproduction number was actually at 1 or below 1 during the summer. What is also interesting is the economic impact, and these are data from the International Monetary Fund, the IMF, and you see that Germany and Switzerland actually had a very similar recession about -5%, both countries, despite the fact that Switzerland had a much larger number of cases and also a considerably higher excess mortality. Now, one slide, that's the next one, will cheer you up in the US. You see that the cumulative vaccination there, the US is doing much better than Switzerland or Germany. The UK is doing better. And of course, Israel is leading the pack with now towards 70% of the population vaccinated in Israel. Whereas Switzerland, Germany, many European countries are not really getting off the ground. The UK is another good example of what can be done in a national health service with a vaccination campaign. Now, let me talk a little bit about socioeconomic position in Switzerland. And let me introduce the neighborhood index of CEP, which was developed in collaboration with Radoslav Pančák, who is also on this call. It was actually part of his PhD. Since then, he's been to Australia and back now in Bern, working with us on these COVID analyses. So the neighborhood index is based on the year 2000 census, but it is updated with the structural surveys that since then have been introduced in Switzerland. It is based on 1.3 million very small neighborhoods of 50 households, which are defined using census and road network data. So a neighborhood needs to be connected with roads. So it shouldn't be cut by some physical barrier. It should really be a neighborhood where people meet and exchange. So the neighborhood socioeconomic position is characterized by the median rent per square meter. You need to know that in Switzerland, the majority of people rent. They don't own a house. So what they pay for the rent is actually a very good indicator of what they can afford. And also the proportion of households headed by a person with primary education or less, so education, occupation, manual or unskilled occupation, and the mean number of persons per room, so a crowding indicator. Now this index is now widely used in Switzerland. The construct validity has been demonstrated using independent data. You can see that income really varies with this neighborhood index. Also, you can see that mortality varies, and the distribution of socioeconomic position in Switzerland, you can see on this slide. And please note that the lowest is red, dark red. So these are the less affluent, low socioeconomic position areas, and the green is the highest. And you see that along the lakes, this is the Lake of Geneva. This is a very expensive place to live. This is Geneva. In general, the urban areas are green. Here we have Bern, Basel, Zurich, Lausanne, and the red areas are sort of along the Alps, the north side of the Alps, and you see that in these areas, socioeconomic position is low, also in the north, in the Jura, and in the east, there are these red areas. When you look at this by population size, then you see that most people live in green areas. So this is by population size, but there are in Switzerland these differences, and these differences do translate into differences in life expectancy. And that's what you see on this slide here, which sort of looks pretty similar to the one, to the one before. So when you look at this one and then at this one, the colors are not identical, but you see that the areas, and this is by gender, by men and women, you see that the areas that you noticed before as red, they're now blue here, and these are the areas with lower life expectancy. And we're talking about several years of differences compared to the high socioeconomic position areas along the lake here again. You see yellow here, and Zurich, the greater metro Zurich area, where people live longer than here. This is the Entlebuch, or again in this area here to the east, and the same you observe in women. So these differences in socioeconomic position, they translate into differences in life expectancy. So this by way of background. Now let's get into the surveillance of COVID-19 in Switzerland. And basically, doctors and labs are compelled or are obliged to report every SARS-CoV-2 test and its result, including PCR tests and rapid tests and sero tests, immunological tests, antibody tests. They are obliged to report COVID-19 diagnosis and obliged to report hospitalizations and ICU admissions, and of course deaths. And this is the database that we are analyzing in this study. So in order to link these data with the socioeconomic position data, we need to geocode all these reports and all these notifications, and then link them to the neighborhood socioeconomic position index. And this was done under a contract between the Federal Office of Public Health and the ETH in Zurich, which is sort of our MIT, if you like, the big technical university. And then we assigned to each geocode the corresponding value of the socioeconomic position of this person's neighborhood. And we removed the geocodes from the database, and we grouped the SEP values into deciles. Okay? So let's have a look at the data that we analyzed. And you see the numbers here. And I should stress, and that's what you see at the bottom of the slide, that the study period really covered the first wave and part of the second wave. And we are now updating the database so that we capture the full second wave. And that will push these numbers up considerably. But still, we have more than 1 million SARS-CoV-2 tests, and 88.5% of these we could link to a socioeconomic position, a SEP neighborhood index. We had about 150,000 positive tests, and about 90% could be linked. We had 6,500 hospitalizations, 776 ICU admissions, and about 2,000 deaths. And particularly the number of deaths will go up quite a bit when we capture the whole of the second wave of the pandemic or epidemic in Switzerland. And you see that we also use the population data, the 8.5, 8.6 million people. And one of the successes of the Science Task Force on COVID in Switzerland was to tell the Federal Office of Public Health that they can't just record the positive tests, that they also need to record the negative ones. And they did that, but only from the 23rd of May 2020 onwards. So that was one of the, we really had influence that the data collection was improved. So the statistical analysis that followed on this data set considered 5, if you like, outcomes where we were interested how they related to the socioeconomic position, the decile that I mentioned, namely whether someone got tested, so the tests, then whether someone tested positive, test positivity, then whether someone was hospitalized, related to a COVID-19 disease, whether this person needed ICU, intensive care, and of course whether people died from COVID-19. So these were our outcomes, if you like, and we had three denominators to relate these outcomes to, namely the general population, and of course that denominator we could use for all five of these outcomes. So tests, positive tests, hospitalization, ICU admission, and mortality. Then we also had denominator tested population. Obviously, you can only be positive if you're tested. So that is a denominator you would use for test positivity. But of course, you can also use it sensibly for hospitalization, ICU admission, and related death. And the third denominator is those who tested positive, and that denominator is relevant for outcomes 3 to 5. So the clinical outcomes, hospitalization, ICU, and death. Statistically, and Julien knows all about this, we used negative binomial regression, so a Bayesian approach, and we entered the socioeconomic position decile as a continuous variable. We also did some analyses where we put them in as categorical, and the model fit was actually better with continuous. We adjusted for age, sex, canton, and epidemic wave. And if you're interested in the methodology we use, then it's really this book here, Bayesian Data Analysis by Andrew Gelman and colleagues, and the software was STAN, which is a relatively, Julien, correct me, easy to use framework for this type of analyses. Okay, so let's look at the evolution of notifications over time. And the colors throughout the results that I will be presenting now are always the same. So there's always blue is the total number of tests. And again, we only have these from the 23rd of May. Then green, the positive tests, yellow, the hospitalizations, and orange and red ICU admissions and deaths. And you see on this slide the two waves, the first wave in March and the second wave up to end of October, but that wave, as you saw before, carried on, and we're now updating the analyses. Now, the next slide shows you notifications or these outcomes across deciles of socioeconomic position, and using these three different denominators. So the same colors as mentioned. Again, remember that decile 1 of the SEP, the SEP index, is the worst and 10 the best. So let's look at the number of tests and denominated per population. And you see that compared, these are relative proportions. So the reference is always the worst, number 1. You see that testing goes up with higher socioeconomic position, and there's really quite a jump in the highest socioeconomic position group, and that we will get back to. And you see that the other outcomes, you see a decline, a tendency regarding positive tests. You see that clearer when you look at per test. So the denominator changes from population to test and to positive test. Now, as I said, we modeled these relationships, and the next slide shows us the model fit and the observed value. Basically, these points that you see, again here blue and green and yellow, orange, red, these are the same data that you saw before, but now you see the modeled estimate, the black line, with its 95% credibility interval. And again, 1 is worst, 10 is best. So let's have a look first at these 3 graphs here. So what you see again is that with increasing socioeconomic position, the number of tests increases, and there's this jump here that we saw before. Now, when we, again, per population, we look at positivity, we see that sort of a U-shaped relationship. So test positivity is high in the lower socioeconomic groups, but there are fewer tests there, so that pushes up the number of positive tests, because test positivity is higher. And at the other end, there are many more tests. So again, we get more positive tests because there is more testing going on. Now, if we look at the same data per 100,000 tests, then we get this very clear relationship that test positivity among those tested is much higher in the low socioeconomic groups compared to the high socioeconomic groups. And this is really influenced by the massive increase in testing at the end, in decile 10, particularly the very high socioeconomic position. Okay, so these are the tests. Now let's go on and look at the clinical outcomes. And here, basically, you see quite a homogeneous picture. You simply see that with increasing socioeconomic position, so people, as they become more affluent, they are less likely to get hospitalized. They are less likely to be admitted to the ICU unit, and they are less likely to die. And you see the same picture when you take the population of tested people, not the entire population as denominator, or the positive test population. You see quite the same picture independently of which denominator you take for your analysis. Okay? Now let's look at adjusted incidence rate ratios per decile increase. So basically what this analysis shows is what happens as you move up towards higher socioeconomic position by 1 step. So from decile 1 to 2 or 2 to 3, etc. And you see it's a relatively complicated slide because it includes data both on the 2 waves, okay, and it includes crude estimates and adjusted estimates. And the adjusted estimates are adjusted for age, sex, canton, and the epidemic wave. But essentially, what you see is that with increasing socioeconomic position, you are tested more, you are less likely to get hospitalized, you are less likely to end up in an ICU, and you're less likely to die. The positive test is, as we saw on the previous slide, confounded by the very different testing frequency across these SEP deciles. But when we get rid of that effect and we look at the population tested, then we see that with each increase in direction of higher socioeconomic position, your probability of testing positive decreases, okay? So essentially, what we saw before is confirmed in this multivariable analysis. What perhaps I should also point out is that as you move from population to test to positive test denominators, the association with mortality becomes, particularly when you only look at positive tests, weaker, and it becomes statistically non-significant. Because part of the effect is now removed, namely the effect of getting tested is removed when you only look at the positive tests. And obviously there is a effect still in the positive test population. And as I said, we will update these analyses, and I predict that this will be much more precise and still an effect will be evident. Now let's look at a few other variables in this analysis, namely age group and sex. And this is what you see on this slide here. So this is adjusted for SCP, but it's not the focus of this analysis. Here we're interested in, across the age span, what happens with the probability of being tested, again, the blue line, the probability of being test positive, the green, the probability of being hospitalized, yellow, ICU, orange, and mortality, red. And this is for the 9 age groups. And you see that the reference group here is either the age group 40 to 49, or for ICU and mortality, it's actually the age group 9 or 0 to 49, this whole age group. And that's why this is flat here, because the number of events is so small here that we had to combine these age groups. There's nothing happening here, okay? So what does this tell you? It tells you that the testing is slightly less in children, but other than that, pretty, homogeneous across the 9 age groups. The test positivity is clearly lower in children, okay? A bit lower in adolescents, and then again, relatively flat and stable. And the probability of being admitted to ICU and of dying really increases from age 50 onwards. So being a bit older is not good news. We know that's nothing new. Then what has also been shown before is that when you look at gender differences, sex differences, then you see that men are doing worse, not for testing. They're tested about at the same rate, but when it comes to the clinical outcomes, hospitalizations, ICU, and mortality, the women are clearly doing better. In other words, the men are doing worse. Okay? Now let's have a little look quickly at the cantons. And the point I want to make here is that there are differences between cantons. For example, you don't see this very well. There is a very strong association in Geneva with the probability of being tested across the socioeconomic position deciles. So people in the high SEP neighborhoods really get tested much more. Geneva is here, okay? Bern is also going in that direction. On the other hand, if you look at the clinical outcomes, for example, ICU admission, there's one canton which behaves slightly differently, has less of a gradient, and that's the canton of Fribourg here. The other cantons are sort of relatively close together. There are a few small ones as well, but this may be stochastic variation. The other cantons are sort of clustering together, and you see the country-wide estimate for decile 10 for the highest socioeconomic position, always on the right, with the confident credibility interval. So there are some differences across cantons. This is perhaps not that much of an interest in the US, but for Switzerland, of course, it is highly interesting. So let me summarize the results. People living in high socioeconomic neighborhoods are more likely to be tested. They are less likely to test positive, be hospitalized, or die from COVID-19. There's some differences in gradients between cantons. And of course, this can be interpreted as a manifestation of the inverse care law. So let's go back to our friend Julian Tudor Hart. Here he is on the Champs-Élysées in a showroom of the Vespa makers. The implication is that clearly testing should be free, and the Science Task Force has pushed for that. During weeks and weeks during the first wave, and only end of June, the government finally introduced free testing. Before that, testing wasn't necessarily free. I'm gonna get back to that in a minute. The threshold for testing should be low, so there should be an abundance of possibilities to get tested in GP practices, workplace, pharmacies, test centers, etc. Information and outreach should be organized and reach these red areas that I showed at the beginning of my talk. And an interesting question is the vaccine rollout. There is this other hypothesis, which is called the inverse equity hypothesis, which stipulates that when an innovation comes along, something new, but really effective, like a new vaccine, that first people in the higher socioeconomic position strata will get access to this innovation. And there's certainly one anecdotal evidence of this happening, namely Johan Rupert, who is a billionaire South African. He owns clinics and other companies also in Switzerland. So he flew in to Switzerland to get vaccinated. And that created a lot of discussion, let's put it that way, in Switzerland. The Swiss healthcare system, it's to some extent similar to the US system, in the sense that it is relatively expensive at about 12% of GDP. The US beats us at 17. These are data from the OECD, I think 2019. There is, like in the US, a market orientation of the health system. There is clearly evidence of overtreatment. So the health system is perceived as something where people can make money, where companies can flourish, etc. What is also noticeable, and that's again, like the states in the US are responsible for health. In Switzerland, it's the cantons. And the system means that each canton has a slightly different approach. It's like dealing with 26 different health systems. And also the data systems don't talk to each other. So the data situation is terrible. And on the good side, everyone is insured, unlike in the US. So it's compulsory to have a private health insurance. The premiums are regulated. They basically depend on where you live in the country, but they're not linked to income. And patients do contribute in the form of deductibles and co-payments. And going back to the test, the COVID test, many people would have had to pay for that test if the government hadn't decided to make an exception and make these tests free. There's also subsidies for people who can't pay the premiums because they are ever increasing. And for an increasing number of people, this is a problem. So about 35% of the population is actually supported. What is also an element that is shared between the US and Switzerland is the relatively high out-of-pocket payment in the system. And you see Switzerland is even higher than the US. So there are parallels in these two health systems. Now, let's go on to the other results, which are perhaps a bit less exciting, but testing was a bit less intense and test positivity was clearly lower in children. And there's a lot of debate about the role of children in the pandemic, etc. So in this context, these results are interesting. The rate of hospitalization increased linearly through the age groups, and ICU admissions and mortality from age 50 onwards. So let me briefly, and I'm coming to an end shortly, talk a little bit about strengths and weaknesses of this study. So the great thing about the study is that we are talking about a country, a population-based national surveillance data set, which will be updated as we go along. We can examine the care cascade from testing to ICU care, whereas previous studies didn't have that sort of unified data set. They focused on one outcome, for example, hospital admission, or among people in hospital, mortality, etc. The different denominators are also very interesting. I mean, in epidemiology, we learned the denominator should always relate to people who are at risk of developing an outcome. But I think in this situation, it's really an advantage to be able to look at the relationships per population, per test, per positive test. And the very consistent relationships that we saw for the clinical outcomes across these three denominators really make it very unlikely that selection bias is distorting these results. And I think the neighborhood socioeconomic position, I think you have similar instruments in the US based on detailed household data is also a strength of this study. Now, limitations, the linkage is incomplete. You saw the percentages. I think with the update, we will be able to push this beyond 90% or 95%. Of course, not everyone who dies of COVID is diagnosed with COVID. So the ascertainment of COVID-19 related mortality is incomplete. And we're now thinking about doing work on looking at excess mortality, which is really the amount of mortality which is higher than expected. And that excess mortality in Switzerland has been substantial, we know that. But we don't know whether it will be possible to relate this to the neighborhood index of socioeconomic position. The graph shows the proportion of COVID-19 diagnosed deaths of all excess mortality. And you see this can be as low in Spain as 60%, or it can be higher than 100%, because in Belgium, you don't need to have a positive COVID test in order to be classified as a COVID death. And that explains these differences. Switzerland is probably similar to the UK, I would say, but we don't exactly know, so 80%. Excess mortality is also interesting because it includes other causes that may be related to the crisis, like suicides. It also includes prevented deaths. The lockdown reduced traffic considerably. So there were fewer traffic accidents and fewer deaths from traffic accidents. It's really the net effect of what this crisis does to the population. Then, of course, we would have loved to have reliable data on comorbidities. It would have been really interesting to have data on individual level socioeconomic position, and also data on lifestyles, smoking, risk factors, etc. So with that, I'm at the end, and I'm pretty much in time, I see. And I just wanted to acknowledge one more time the people without whom this work would not have been possible. I think at least two of them are on the call. Julien, thanks very much. Radek, thanks very much. And over to you, Bert.